From Faithful Word Media, this is Healthcare Musings. I'm Dr. Hesham Hasabala. Hey everybody, Hesham Hasabala here. Another episode of Journal Club. This time it's an article that's been published for a bit now, September 19th, 2024 in the New England Journal of Medicine, and it's entitled Long-Term Oxygen Therapy for 24 or 15 hours per day in Severe Hypoxia. So this was a study out of Sweden. It was a multi-center, registry-based randomized controlled trial involving patients who were started on oxygen therapy for chronic severe hypoxemia at rest. And so just to give you a sense of who these patients were, so they had a mean PO2 on room air in the 24-hour group of 48.8, and it was the same in the 15-hour group. And that, it's interestingly, that corresponded, their mean SpO2 on room air was 78% in the 15-hour group and 82% in the 24-hour group. So interesting, they were more hypoxic in the 15-hour a day group. So the study was conducted between May of 2018 and April of 2022. No patient was lost to follow-up, and it was a non-superiority trial, and the patients were eligible for inclusion if they had a resting PO2 lower than 55 or an SpO2 lower than 88 on room air, or if they had heart failure or polycythemia, which is a hematocrit greater than 54%, then their PO2 is less than 60. So those were the patients that they recruited. Now, interestingly, after about 110 patients underwent randomization, they amended the trial protocol because of slow recruitment. And they changed the non-superiority margin, which is the lower boundary of the 90% confidence interval, from 0.83 to 0.67, which they said was clinically significant and more conservative than the threshold for the long-term oxygen treatment trial, which there the hazard ratio was 0.6. So they said, it was slow to recruit, which can happen in these kinds of trials, and so they actually made it more clinically significant and more conservative. So these were pretty hypoxic patients at baseline, and so they randomized one group to get 15 hours a day and the other group to get 24 hours a day. And the way they did that was, but before we go there, their mean FEV1 was 1.2 liters. The median, this is in the 24-hour group, and in the 15-hour group, that's 1.3 liters. The median was similar. The FVC was 2.1 liters in the 24-hour group and 2.4 liters in the 15-hour group. So again, pretty severe lung disease, and the mean oxygen flow is just under 2 liters a minute. Okay, so those were the patients. And so what they did was they told the 24-hour group, obviously, use it all day and all night. In the 15-hour group, they said you can use it when you're sleeping, and then don't use it for 9 hours during the day. And so what they wanted to see, were they worse off if they used oxygen for less? And what they found was, they changed the outcome, the primary outcome, they changed it. And so the risk of hospitalization or death within 1 year was in the 24-hour group was not lower than the 15-hour group. And so the mean rate of the 24-hour group was 124.7 events per 100 person years versus 124.5 events per 100 person years in the 15-hour group, and that was no difference. Okay, and then they had a whole bunch of secondary outcomes. Let me open the table and kind of go through what they found. So there was basically no difference in the secondary outcomes as well. And what's interesting is that the percentage of death from any cause in the 15-hour group was lower, 27.4%, versus the 24-hour group, 31.6%, which I thought was interesting. It's not statistically significant, but I thought that was interesting. Also, then they had similar numbers of hospitalizations. And they had a whole bunch of different quality of life scores, and they found no difference between either group, right? So they had like this facet scale score, CAT score, EQ5D score, and and also the MDPA1 score. So that MDPA1 was for unpleasant breathing, and they found, if it's higher scores is more unpleasant, and it was actually lower. It was 4 versus 5. The facet scale is a fatigue scale, and higher scores are meaning less fatigue. It was 22 in the 24-hour group versus 23 in the 15-hour group. The CAT is a health status score. Higher score is worse health status. They actually had a lower, 19 versus 21. And then that EQ 5D VAS is perceived well-being. With higher scores is better. The only difference is that they had a lower perceived well-being of 45 versus 50. 45 in the 15-hour group versus 50 in the 24-hour group. So basically, very similar and kind of long like quality of life scores. In addition, they did subgroup analysis, and they found that if anything, all of the hazard ratios for hospitalization and death tended to were the same between the 15 and 24-hour group, and if anything, they trended toward having 15 hours per day be better. But again, there was no statistical significance in these findings. So overall, they found in this study that using oxygen for just 15 hours a day was not worse than using it for 24 hours a day, and that's I think that's clinically significant. That's actually a big deal, and we'll talk about why a little bit later. But just one thing we have to note, that when you look at when they reported daily use at 3 months versus 12 months, there in the 15-hour group, most used it around 15 hours, but some used it up to 24, and others used it between 9 and 10. At 12 months, the range was even wider. There was more that used it all day, and some that used it not at all. Same thing in the 24-hour group. Most used it up to 24 hours, but then at 12 months, the range widened a little bit. So did that have an effect? That's unclear. A question I had is, okay, it's no different, but if you use oxygen for less during the day, do you then have more pulmonary hypertension long term? They didn't answer that question. This was not a long-term study. I'm very interested to know whether these people get worsening polycythemia down the line. Do they get worsening pulmonary hypertension? That was not answered by this by this study. The strength of the trial was that this was a national registry-based randomized controlled design, and nobody was lost to follow-up, and the outcomes were very easily measured. Again, a big limitation is that because of insufficient recruitment, they had to amend the protocol, and then the wide limit of to show non-superiority, that they said that a benefit of long-term oxygen therapy used for 24 hours in reducing the risk of hospitalization or death within 1 year cannot be excluded. Again, because of the way they did the statistics, they can't exclude that there is a benefit. And all said, I think this is a great study, because now it's I've taken care of people that have been admitted to the hospital after tripping on their oxygen therapy at home, and they break their hip, and that could be deadly for someone who was elderly. The other thing is, some people are self-conscious with oxygen. They don't want to go out and lug an oxygen tank or a concentrator and walk around. Maybe if you want to just go to the park during the day, or just take a walk outside. The study says that it's probably safe, that you don't have to have the oxygen all the time. That if you want to go out to dinner or go to a friend's house and you don't want to lug an oxygen tank, up to 9 hours a day, you should be okay. So I think this is really good. It gives patients flexibility, and hopefully that'll give them a better a better quality of life. That they can use oxygen. That it'll help them. They won't be worse off by not using it all the time, 24/7. And so I think this was a great study, and it will definitely be practice changing for me, and which is why I wanted to share it with all of you. Thanks so much for your time and attention, and until next time, Hesham Hasabala signing off on Healthcare Musings. Thank you for listening. Sign up at healthcaremusings.com to get every episode delivered directly to your email. And please don't forget to leave a 5-star review. Thank you so much.